Hi, welcome back to our neuro content. So we are starting on intracranial regulation, which is 11A. This is where there's one long PowerPoint for the next 3 recordings. I did break them up for you in different outlines because I felt that that would be easier for you. So in this one, we're going to talk about intracranial regulation, which is really increased intracranial pressure or increased ICP. Touch on brain tumors, meningitis and hydrocephalus, and meningitis and hydrocephalus share a whole lot of commonalities. So be sure you have your outline so that you can take some notes. So you've got some just general information about intracranial regulation and what it is, and it's the as we've already said, our nervous system is our body's control center. I really think of my brain as my computer, and it coordinates all functions, because if my brain doesn't work, nothing else works, from muscle movement to senses to thoughts and emotions. And like I said, it works by receiving information, processing information, and creating a response. The brain also has the ability to adapt to changes within what's going on with the skull. And the way to think about this is really what's called the Monroe-Kelly doctrine, or the Monroe-Kelly hypothesis. And so I made you a little oval on the screen to look like your brain. And so our brain is in a nice closed environment inside of our skull. And it's 80% brain, 10% CSF, cerebral spinal fluid, and 10% blood. And if any changes in one of these, the others have to change. That's the Monroe-Kelly hypothesis. That if my brain swells, then my CSF and or my blood have to decrease, because I'm in this closed environment that can't be over 100%. Now, technically your brain can move. It can go down through your brainstem, which is called herniation, and that is brain death. So this is the principle of what we use, that any change in one. So in hydrocephalus, I have increased CSF, which means I'm putting pressure on my brain, and decreasing blood flow, which means decreasing oxygen to my brain. Okay, so let's talk about intracranial pressure, because in the ICUs, when they put a bolt, it is called a bolt, into their brain, we can actually measure their ICP. If I don't have a bolt, I can't measure ICP, but I can get an idea of what it is doing my neuro assessment. So intracranial pressure is normally 0 to 15. Some of these numbers differ from what your book has, because some of the book's numbers are a little bit crazy. So we're going to go with this 0 to 15, because this is common across lots of different references. If the ICP is greater than 20 for more than 5 minutes, that is a life-threatening event. And we have to do something about that. So that is increased intracranial pressure. Then we have what's called CPP, cerebral perfusion pressure. So a normal CPP is 70 to 100. And this is where it's very different. Your book says it's 50. If your CPP, though, is less than 50, you have significant lack of perfusion to your brain, and you're going to have a significant brain injury and probably not survive. So that number is just crazy. It is 70 to 100. We need it to be high enough that we're perfusing the brain, but not so high, because if it's over 100, we're actually putting a lot of pressure on the brain. We do have to calculate CPP. CPP is MAP, mean arterial pressure, minus the ICP. So it's the amount of blood pressure going up to my brain to be able to perfuse my brain. Any factor that decreases MAP and or increases ICP will decrease CPP. So that's important. The goal is to maintain an ICP of less than 20 and a CPP of greater than 70. So it's bolded, it's underlined. You should probably highlight that. That's important to know. Ischemia develops with inadequate CPP. If it's not corrected, it will lead to tissue death. Okay, so it's important. And this whole If my MAP is too low, we know that we don't have enough blood supply going to the brain. So we may have to do something about that. Or if I have increased ICP. Both of those will decrease your CPP. Treatment is really focused on decreasing ICP because that fundamentally is the problem of what we're having. Now, we have autoregulation of these cerebral vessels, and that is the vessel's ability to dilate and constrict as they need based on perfusion. And we already talked about that in relationship to PaCO2 and PaO2. And that can happen. And that's the body's trying to help, but we need to do the things that we need to. So if that ICP is greater than 20 for 5 minutes or longer, that is a medical emergency and I need to fix that. All right, so we're going to look at this little table. I took this from a med-surg book many years ago because I liked how it did, because it took all the pieces of Monroe-Kelly doctrine. So we have increased brain volume. So why our brain volume increases? We have increased blood volume in the center and increase in CSF or cerebral spinal fluid. So why do we have increased brain volume? It really is from cerebral edema, which is from injuries. So they did split it out between cytotoxic and vasogenic. What you need to look at the causes: stroke, cardiac arrest, hyponatremia, brain injuries, brain tumors, meningitis, abscesses. And you will see that meningitis flows across here in several places. So this is how we're going to talk about brain tumor. Y'all already know about cancers, but what happens with a brain tumor? I have abnormal cells, so my brain gets bigger because of the tumor, which means it's squishing the rest of the brain, which means it's not getting blood flow and oxygen. That's why brain tumor is a problem. Increased blood volume. This is loss of autoregulation because the brain can no longer autoregulate itself. Decreased cerebral oxygenation will cause this. Hypoxemia or hypercapnia, so low PaO2, high PaCO2, and then things that increase our metabolic demands. And look at this list: fever, physical activity, shivering, seizure, pain, stimulation. Those are all the things that I can control and do with my patient as a nurse. So this is really where I'm going to focus my interventions. Increasing interthoracic or interabdominal pressure. So remember when I talked about learning to suction an ET tube and said that remember that when I suction, I have increased interthoracic pressure, which increases intracranial pressure, which is why it's important that we only suction when we need. We limit suctioning to 10 seconds and we only do it twice. And then obstruction of venous outflow. So when we talk about what we're going to do for these patients, we keep their head and neck in neutral position, which means their head is setting at midline and it's not kinked over to the right or to the left, because that would kink off my venous return where I would not have as much blood coming out of my brain. And then causes of increased cerebral spinal fluid, which is actually hydrocephalus, and that's blockage of the normal flow. It can be poor absorption from things like subarachnoid hemorrhage, meningitis, encephalitis, so we see those all the time in the units, or overproduction of CSF. That does happen. Hydrocephalus, which we'll talk about in a little bit, can be congenital, and I do know adults who've had overproduction of CSF, and they have to come in routinely and have lumbar punctures and have CSF drain. Have that excess CSF drain off. And I'll let you think about what you think that their most common complaint is. If I have too much CSF in my head, I'm probably going to have a headache. Okay, so another little table that I have kind of a love-hate relationship with is these are signs of increased intracranial pressure. There's early and late. When we get to the late, you'll see why I have kind of a love-hate relationship, because I'm like, really? So changes in LOC. The first sign may be restlessness or agitation, delay in response to questions, slowing of speech. So they're still awake and alert and oriented, but they are responding to you slower. That should set off alarm bells for you. Pupillary changes, headache, weakness on one side of the body. Those are all early signs and symptoms, and we need to catch those early. These patients with brain injuries, we're going to do Q1 hour neurochecks on them. So we should see these and we have to report these. And then our late symptoms, because these are just kind of silly. Loss of consciousness or coma. But I will tell you, they can have early symptoms and progress to late symptoms within 15 to 20 minutes. Vital sign changes. Decreased heart rate. Bradycardia, as I've already said, in a neuro patient is bad. Decreased respiratory rate. Increased blood pressure. Increased temperature. Their hypothalamus can no longer regulate their temperatures, and they will have very high temperatures, 104 and higher. And then Cushing's triad. So you see this all the time. It's real common in things like ATI, and it's actually a really late sign. So what happens in Cushing triad is you have widening pulse pressure. Pulse pressure is the distance between systole and diastole. So what happens is we have systolic hypertension. Their systolic pressure goes up, but their diastolic doesn't change, which means that pulse pressure widens. So I talk about it both ways: widening pulse pressure, systolic hypertension. They have bradycardia and changes in respirations, meaning they have Shane-Stokes. They're about to herniate and die. Projectile vomiting, late signs, hemiplegia, posturing, loss of brainstem reflexes, cough, swallow, gag, swallow, pupil, cough. Those are all late signs. Okay, so let's look at what it looks like when we are monitoring these patients. So the purpose to do intracranial pressure monitoring is to assess the response to therapy and augment our neurological exams, because patients never follow the rules in neuro. It's very difficult to chart. I find the best thing to do is to chart, this is what I did, and describe the response back from the patient. They just don't fill in the blocks, and they don't fill in the blanks, excuse me. So two things that we're going to do. Here's our little bolt. This is a picture from your book. It's 11.12, so I highlighted the bolt. This is going to give us intracranial pressure, and then our intraventricular catheter, or which we can get pressure from, and we certainly can do a drain to drain off CSF. This is people who are bleeding in their ventricles, because you have ventricles in your brain as well, and so it's called a ventric drain. And this is one in real life. I did not take this picture. And you can see that it's bloody because the patient had a traumatic brain injury, so their CSF is bloody. That would be expected. I don't like it, but that would be expected. So we can see these. So we can just see a bolt, and we can just see a ventric drain draining off fluid. With a ventric drain, you can get their ICP, or we could have both. So let's talk about management of ICP. So when you get to this, when you look at your little outline, you have what I call Neuroman, because we've already had Bypass Man. So this is Neuroman. I believe I have uploaded this as a picture just by itself into a Word doc. If not, you can just right click and copy it out. And you need to look at everything that's going on with him, because this will help you understand what we're doing, why we're doing it, and how to take care of this patient. So first and foremost, it's assessment. Assessment in a neuro patient, fundamentally an assessment in any patient, is the most important thing that you're ever going to do, because you're assessing to see where this patient is baseline, and does my patient have any changes during my shift. So we're going to do a neuro exam. We're going to look at LOC. We're going to look at pupils, neurostatus, ICP, CPP. We're going to look at vital signs. We're actually going to look at INO because of some of the treatments that we're going to give. We're going to call for any changes in condition, vital signs including temperature, breathing patterns, sustained elevated ICP. ICP greater than 20 for more than 5 minutes requires treatment. In bold, exclamation point. Our nursing interventions to manage ICP. We're going to position them to minimize ICP and maximize CPP. Really, that's head of bed at 30 to 45 degrees. Sometimes they say 30. I just do 30 to 45 because we've learned that for that bundle, so it still works. We're going to put their head in neutral position, promote venous drainage, which I've already talked about. We're going to cluster care or space out our activities, however you want to think about that. And remember, we are the ones taking care of this patient and managing this patient, which means we need to manage our other therapies coming in, PT, OT, speech, respiratory, any of that has to happen. We need to manage that to make sure that we have a therapeutic environment that's quiet and calm for these patients. We've talked about suctioning only when it's necessary. Minimize noise, stimuli, light. That does not mean our families cannot come in. Our families can come in. They can sit quietly at the bedside. They can hold their loved one's hands, because that patient's going to respond more to their family than they are to us and me, that loud ICU nurse. So they can be there. We just have to explain to them that it needs to be quiet. We need to prevent complications from infection, especially if we have ICP bolts in, a ventriculostomy tube in, an ET tube, a central line, Foley catheters, whatever tubes, lines, and drains that we have. They will have nutritional deficits because they can't eat, so we're going to have to tube feed them. They're going to have problems from immobility, so we're going to do a VTE prophylaxis. So these are the things that you can look at in this picture. You'll also see that they're doing EEG monitoring. Let's see if we're having seizures or brain activity. They're going to be on a monitor. In our neuroman, he's got a C collar because he's a trauma, so we've got to keep his C-spine stabilized. Diagnostic tests. We may look at ABGs, electrolytes, because I don't need electrolyte problems. H&H, serum osmo, kidney, liver functions. We'll do a CT, an MRI, EEG. We may do blood flow, lumbar punctures, all of those things. And we're going to call with any change of condition. I cannot stress that enough. The way I think of it is 0 to 15 is normal. If my ICP is 15 to 19, I am standing ready to treat this patient. If I'm doing basic nursing care, I am turning my patient, I'm doing my oral care, I'm going to look at that ICP, and if it goes up, what am I going to do? I'm going to stop stimulating my patient and see if it comes down. The longer it takes for it to come down, the less autoregulation that brain has. If it came down quickly within 5 minutes today, 2 days from now, it's taking it 10 or 12 minutes to come down, that brain is worse. And those are all things that you need to monitor. Oops, sorry about that. All right, so let's talk about meningitis. This is inflammation of the meninges, which cover the brain and the spinal cord, and it can be from bacteria, viruses, or fungus. It can also be secondary to things like cancer or anything that weakens the immune system. So HIV, or an opportunistic infection, which is in patients who have AIDS, and we will talk about HIV and AIDS in a week or so. So let's talk about bacterial versus viral. Bacterial is the bad one. It's the most dangerous. It's rapidly progressing. That bacteria enters the central nervous system from an infection in the body. So it could be an ear infection, a sinus infection. It can come from their lungs, or it could be from a head injury or any other site. It's most often strep pneumoniae or this Neisseria meningitis. And it's often contagious and requires droplet precaution. And if it's contagious, then we need to find out who these people have been with, because they're going to need prophylactic antibiotics. Viral is the most common, and it's generally less severe. It's caused by a host of things that you've got listed. Herpes virus, mumps can cause this. While it is often self-limiting, usually they get better within a week or two. There are some antivirals that we could give them. So you have some pathophysiology about this and how this works. There is a piece on prevention. There is a meningococcal vaccine that is given at age 11 to 12 with a booster again at 16 years. So that is important. Hopefully you learn that during lifespan, and vaccines. First-year college students, member of the military, that haven't been vaccinated are at highest risk because they are now living together. And if one person gets meningitis, they all get meningitis. Okay, so let's talk about what these people look like. So they do have a triad of symptoms: very high fever, severe headache, and stiff neck called mucorigidity. They're going to have fever, and that may be their initial symptom. And it usually remains high throughout the whole course. Headache because of the irritation to the meninges and that really stiff neck. They're going to have photophobia. They could have a rash, especially if it's the meningitis kind of infection. They can have petechiae. They could have purpura. On large areas of their body, on their body and large areas of ecchymosis. They're going to have altered mental status. They can have seizures. There's two different tests that we can do for them. So I took the little JPEG from your book, and I don't think it had a number because I don't see it in my notes, but it's within this section of a positive Koenig sign, and that is when the patient is lying with the knees flexed on the abdomen, the leg can't be completely extended back down. And the other one is the Bruniski sign, and when their neck is flexed, and be sure don't do this if you suspect a cervical cord injury or trauma, there's flexion of the knees and hips, and those are both pretty positive for meningitis, so you will see us use those. Diagnostic tests, certainly lumbar puncture. If we do think that they have increased ICP, we won't do the lumbar puncture. We're going to get samples of the CSF and send that to the lab. There's usually 4 tubes, and we do different tests on each tubes. Bacterial will likely be cloudy. It does have high protein, high white count. Viral will be clear. Usually the WPCs are normal or might be slightly elevated. We can do a CT and MRI, certainly a CBC, a basic metabolic panel. We might want to do blood cultures. We test for meningitis a whole lot. We don't see it positive as much, but remember they need droplet precautions because oral mucosa, oral secretions, nasal secretions, those are all considered infectious. Pharmacology will give them antimicrobials, rifampin, ciprofloxacin is on here, ceftriaxone. Dexamethasone can also be given. We need to give them fluids to treat in case they have dehydration or try to have some kind of shock state. Anticonvulsants to prophylax for seizure activity. They need pain control, antipyretics, and any kind of treatment for increased ICP, which we will talk about. So droplet precautions, frequent neuro, reduce their fever, elevate the head of the bed. So same treatment that we've talked about for increased ICP, which we have talked about. For infants with meningitis, they will have bulging fontanelles, they will have a high-pitched cry, poor feeding, and extreme irritability or lethargy. So very classic symptoms. Some of those signs and symptoms and our treatments or our assessments are shared between meningitis and hydrocephalus. So let's talk about hydrocephalus. We've already talked about these 3 reasons we might have increased CSF: blockage of normal flow, obstruction of reabsorption, which can be some head injuries, and excessive production. So it could be congenital, which is a increase in ICP because of the CSF buildup, and that is treated with a VP shunt. So they put a shunt from their brain down into their stomach. Acute hydrocephalus is sudden onset, and they can be stuporous or comatose. That can be managed with the shunt. I have seen shunts put in adults as well. It can be subacute with delayed onset with gradual drowsiness, behavioral changes, ataxic gait. Is also treated with a VP shunt. So infants, rapidly increase in head circumference, bulging, tense, roll, tight fontanelles, irritability, lethargy, poor feeding, high-pitched cry, same thing with meningitis. Older children and adults will have those headaches, worse in the morning, nausea, vomiting, blurred, double vision, balance, gait issues. So we need to do neuroassessment. For an infant, we do need to check their head circumference, assess those fontanelles. We do need to do shunt checks, if they've got a shunt, look at the incision site for signs and symptoms of infection or CSF leak, and monitor for shunt malfunction, which means we're seeing reoccurring symptoms of hydrocephalus. Raise the head of the bed, keep that head and neck in neutral position, cluster care, minimize stimuli, same things we've talked about for increased ICP. And if you're dealing with a baby, we really have got to support that very large head. And infants with hydrocephalus can have some poor outcomes. All right, that ends this section on increased ICP, brain tumor, meningitis, and hydrocephalus. Thanks.